Next, we have our insurance expert and Medicare expert, Monica Fawzi Bryant. This is, I think, the third or fourth presentation that you've done for us, Monica, and it's always extraordinarily well received. So, and there probably have been some questions on the board for you as well, Monica. So please do try and answer some if you do have the time. I know you're doing mommy duty as well as amyloidosis duty, and we do appreciate it. So take it away.
My pleasure. And I will definitely stick around until the kids come back to answer questions. But in the meantime, I want to get right into it. So today I'm going to talk about insurance and finances. But for those of you who don't know, I co-founded an organization, a nonprofit called Triage Cancer, that provides education on all of the legal and practical issues that impact individuals. And up front, we have 20 minutes, and inevitably there will be questions that come up even after today. And I want you to know that Triage Cancer can be a resource to you for the future. So one of the challenges with talking about health insurance is that it's confusing. And to really understand and make the most of a health insurance policy, we have to understand the terms that are being used in that policy. But it's like learning another language that no one ever teaches you. So if you feel like you don't really understand your insurance and you're very frustrated by that, you are certainly not alone. There have been multiple studies done showing that less than 4% of Americans can accurately define the most commonly used terms. So that's where we're going to start today. And these are the terms that are going to be used in your policy regardless of how you get insurance. So there are three main places we get insurance in this country. The largest number of Americans still get their insurance from an employer. The next largest group gets their insurance through a government-run program, primarily through Medicare and Medicaid. And then the smallest number of Americans go directly to a health insurance company to get their health insurance. But as I mentioned, these terms are going to apply regardless of where you get your insurance. So specifically around the costs, there are some terms we need to know. Your premium is what you have to pay every single month just to have health insurance. And you're going to pay this amount whether you see the doctor or not. It's like having car insurance all year and never submitting a claim. But then there are some extra costs that you have to pay when you actually go and use your insurance. The first is your deductible. And this is a fixed dollar amount that you have to pay out of pocket before your health insurance company starts picking up their share of the cost. And the deductible starts back at zero every single year. Now, you could have a plan with a $5,000 deductible. You could have a plan with a $500 deductible. It just depends on your plan. Now, the amount that the insurance company is responsible for is called the co-insurance or the cost share, because you're literally sharing the cost. And this is a percentage, and you're going to pay this each time you get care. So if you have a plan with a cost share of 80-20, that means once you've met your deductible, your health insurance company is responsible for 80% of your healthcare costs, and you're responsible for 20%. Now, some policies also have an additional payment called a co-payment. And this is, again, a fixed dollar amount, and it's going to depend on the policy, but you pay it each time you get care. So, for example, many policies have a $25 co-payment each time you go and see the doctor, or a $250 co-payment if you end up in the ER. Now, perhaps the most important thing for you to understand about your health insurance is the out-of-pocket maximum. Because theoretically, this is the most you're going to have to pay out of pocket in a worst case scenario. And the way you get to the out-of-pocket maximum is typically by adding up everything you pay towards your deductible, everything you pay towards your co-payments, and everything you pay towards your co-insurance. So it's literally everything you're paying out of pocket except those monthly premiums. Now, I said typically because the devil's in the details. So usually plans will only count payments made towards in-network providers towards that out-of-pocket maximum. And some employer plans actually carve things out of the out-of-pocket maximum. For example, my plan doesn't count co-payments towards that out-of-pocket max. So important to know how your specific plan handles this. But here's an example of why it's so important. Meet Dan. Dan has a policy with a $2,000 deductible. It's an 80-20 co-insurance, and he has an $8,000 out-of-pocket maximum. If Dan ends up with a $102,000 hospital bill, and assuming he hasn't had any other medical care for the year, what does he have to pay? Well, the first thing we always pay is that deductible, which leaves $100,000 left of the bill. He has a 20% coinsurance, which would be $20,000. But thankfully, he has a policy with that out-of-pocket maximum. So since he's already paid $2,000 towards his deductible, he only has to pay another $6,000 to meet that out-of-pocket maximum, and then the rest is handled by the insurance company. So I am not suggesting that $8,000 isn't a lot of money. Of course it is. But it's all relative when we start looking at what the alternatives are if we didn't have out-of-pocket maximums or if Dan didn't have insurance at all. So if you would like to hear any of that again, or you think that there's somebody else in your life that would benefit from hearing that, all of the terms I just talked about in this example is included in one of our animated videos. It's available on triagecancer.org. It's in English and Spanish. So please feel free to share and check it out as you think would be helpful. Now, there's a whole set of terms that are related specifically to prescription drugs. And so the first is the formulary. Now, the formulary is a fancy term for a list of drugs that the insurance company is going to cover and at what rate. Typically, formularies are going to be broken into tiers, and depending on where the drug falls on the tiers, it's going to be covered at a different rate. The highest amount of coverage is usually in that tier 1 where it's a formulary generic. The lowest coverage, which means the highest cost to the patient, is going to be in that specialty category. And unfortunately, that is where a lot of oncology drugs fall. But when we're talking about prescription drugs, it is really important to understand how your policy handles them, because some policies have different deductibles or co-payments, or even an out-of-pocket maximum specifically for prescription drugs. Now, I know that there are a lot of questions about specific drugs and where they're covered and how to get coverage for them. And it is important to know that when we talk about prescription drugs, if something isn't covered or it's being tested in a clinical trial and you're trying to gain access to that and you can't, there is a type of appeal called an exception request. And if you're interested in learning more about that, we do have information on our website, along with an hour-long webinar that's archived that you can watch to learn more. Now, in 2014, because of the Affordable Care Act, also known as Obamacare or the ACA, we were given a new way to shop for health insurance, and that's through the state health insurance marketplaces. Sometimes they're also referred to as exchanges, but no one really knows what either of those things mean. So the best way for me to explain them is they are like Amazon for health insurance or a shopping mall for health insurance. What you are buying in these marketplaces is in the top of our triangle of coverage. It's plans from private health insurance companies just being sold through the marketplaces. So you may wonder, well, why would I go through the marketplace? I could just go buy insurance from the insurance company. And that's true. You still can do that. But there might be some advantages to buying through the marketplace. For example, there's a cap on the out-of-pocket maximum. So for this year, they can't be more than $8,150 for an individual. There may also be some financial help in the form of premium tax credits or cost-sharing subsidies based on your household size and income level. Now, there's been a lot of politicization of the Affordable Care Act, but I have to say, after doing this work for over a decade, this is one of the most important things that we want people to know about, that they have access to health insurance through these marketplaces, because we still have about 10% of the population that don't have health insurance, and we know a large percentage of those people could get essentially a free bronze plan in the marketplace if they just knew about it. Now, the other thing I wanted to talk about today was Medicare, because I know a lot of you are coping with Medicare. Medicare is the federal health insurance program for individuals who are over the age of 65 or have been receiving Social Security disability insurance for 2 or more years, or have end-stage renal disease or ALS. So the challenge with Medicare is lots of Americans are on it, and it is incredibly confusing. And one of the reasons it's so confusing is because there's actually not just one Medicare. there are 4 different parts to Medicare. So Part A is your hospital insurance. This is typically going to cover inpatient stays. Now, if you've worked and paid into the system over your working history, Part A is actually going to be what's called premium free. But there are still deductibles and cost shares associated with Part A depending on how long you actually are inpatient. Now, if you haven't worked and paid into the system, you can still access Part A. You're just going to have a monthly premium for that. Now, Part B is your medical insurance. So that's going to cover doctor's visits and outpatient care and immunizations, and lots of IV treatments are going to be covered under Part B. Now, even if you've worked and paid into the system, there is still a cost associated with Part B. The monthly premium for 2020 is $144.60 for most people. For people with incomes over a certain amount, their premium is actually going to be more. Now, there's also an annual deductible associated with Part B of $198 per year. There's also a cost share. So the Part B cost share is 80/20, which means that after you've paid your $198 deductible, you're responsible for 20% of all of your medical bills. And there is no out-of-pocket maximum with Part B. When we talk about Part A and Part B together, it's often referred to as original Medicare because it's all that existed when Medicare was first passed. And original Medicare is fee for service, which means if you have original Medicare, you can go to any provider around the country that accepts Medicare. Jumping over to Part D. Part D is prescription drug coverage. Now, most people are surprised to learn that Medicare didn't have prescription drug coverage until 2003, but these plans are actually provided by private insurance companies. So the plan costs are going to vary company to company, and the benefits are going to vary company to company. But in 2020, the deductibles cannot be more than $435. So you could have a deductible of less than that, but that's the ceiling. Now, when Part D was originally passed, it was passed with a gap in coverage. And it was a period of time where Medicare didn't pay for anything associated to somebody's prescription drugs. And that gap became known as the donut hole. So in order for me to explain where we are now, we have to go back in time and look at how the donut hole worked prior to the Affordable Care Act. So here's how it would work. At the time, the patient would be responsible for their deductible of $295 out of pocket. Then they entered the initial coverage phase, during which Medicare would pay 75% of their prescription drugs and the patient would pay 25%, until their total drug costs got to $2,700. Then they'd enter the donut hole, during which Medicare would pay nothing and the patient would pay 100% of their prescription drugs, until the total out-of-pocket drug costs reached $4,350, and then they would enter the catastrophic coverage phase where Medicare would pay 95% and the patient would pay 5% or a nominal dollar figure, whichever was more. So as you can see, there was this period of time where patients were responsible for all of their prescription drug costs. Now, when we're talking about really expensive therapies, people would often go in and out of the donut hole in one prescription or one treatment. So it was a significant problem. The Affordable Care Act did several things to improve Medicare, including closing the donut hole over time. It is officially closed as of 2020, and this is how Part D coverage works as of this year. You pay your $435 deductible, then you enter the initial coverage phase, during which Medicare pays 75% and the patient's responsible for 25%, until the total out-of-pocket costs reach $6,350, and then they're in that catastrophic coverage phase. So as you can see now, their patient's still responsible for some part of this cost, but there's at least some Medicare contribution all the way through. So that is a significant change to how Part D works. So we've covered Part A, which is hospital insurance. Part B is medical insurance. Part D is prescription drugs. Turns out, potentially dealing with 3 different premiums and 3 different deductibles and 3 different co-insurances. It's a lot to keep track of. So an alternative was created in Part C, otherwise known as Medicare Advantage plans. Now, these again are sold by private insurance companies, Humana, Aetna, Blue Cross, and they operate very much like individual insurance with respect to there could be HMOs or PPOs. They have different benefits associated with them, so the costs are going to vary plan to plan. But what happens with these Part C is that all of your benefits that you would get under A and B are bundled into a managed care program. 90% of Advantage plans also include prescription drugs. So the other benefit to these Advantage plans is that there is an out-of-pocket maximum. And in 2020, the out-of-pocket maximum can't be more than $6,700 for in-network providers. And again, that's the ceiling, so there could be lower out-of-pocket maximums. But this is usually when we're in person that somebody raises their hand frantically and says, but which is better? And the answer is it depends. It depends on what's available to you. It depends on what you are. Certain benefit Advantage plans as compared to original Medicare, you're paying 20% all year. Downside, Advantage plans are going to have a much smaller network of providers. And I know that for some people with particular illnesses, they want to go see specialists in different states. So an Advantage plan may not be the best for you. So if somebody chooses original Medicare, which again is A and B, and there's those out-of-pocket costs, what can you do to protect yourself? Well, the option is to purchase an additional insurance policy called a Medigap plan, also known as a Medicare supplemental plan. And these plans help cover those out-of-pocket costs. Now, I purport that one of the reasons that insurance is so complicated is we have multiple names for exactly the same thing. The other reason is we have names that aren't very good. For example, Medigap plans are identified by letters A through N, not to be confused with Medicare parts A through D. So why we couldn't come up with any other naming system, I don't quite know, but they haven't put me in charge yet. So the most comprehensive plans were plans C and F. Those are no longer available for purchase for people who are newly eligible starting this year. If you've had a C or F in the past and you've continued it, you get to keep it moving forward. It's just for newly eligible people. Those aren't an option anymore. And I can see the question box just blowing up over here. So here's what happens when you are trying to decide what your Medicare options are. You have 2 lanes you get to drive in. The first is original Medicare, where you pick up Part A for your hospital insurance, Part B for your medical insurance. You ask if you want a prescription drug plan. I hope the answer is yes, and you pick up a Part D plan. Then you decide if you want to purchase an additional insurance policy called a Medigap plan to cover those out-of-pocket costs. That's lane 1. Lane 2 is a Medicare Advantage, otherwise known as Part C. In this lane, you pick a plan where all of your Part A and Part B services are bundled in one plan. If that plan doesn't have prescription drugs, then you can pick up a Part D plan, and that's where your choices end in lane 2, because lane 2 also comes with that out-of-pocket maximum. So I know I went really fast based on time, but please know that there are resources where you can get more information. I just did a webinar this month that's archived on our website. We also have what we refer to as quick guides, which are 1 to 4 page documents that can be downloaded and printed from our website, and you can find all of those on the Triage Cancer website. So I want to just quickly go through how we can make choices when we are presented with more than one insurance option. So the analysis I'm about to do works if you're trying to compare 2 marketplace plans, if you're trying to decide between 2 plans your employer offers you, or if you're trying to decide, hey, is my employer plan the best option for me, or maybe is a marketplace option better? Or even if you're trying to decide between 2 Medicare plans, either Part D plans or an Advantage plan. So I'm going to use the marketplace as an example, but remember, this analysis works regardless. So assuming that you're going to hit the out-of-pocket maximum each year, and most people that I present to in a year are going to hit that out-of-pocket maximum, this is how you do the math. So here we have 3 different policies with 3 different premiums, 3 different deductibles, 3 different out-of-pocket maximums. That one on top looks relatively affordable at $173 per month. You look at the bottom one, you're, wow, it's $400 a month. But what's going to cost you the least at the end of the year? I can't actually tell just by looking at this. I have to do the math. And the way that you do the math is by taking the monthly premium and multiplying it by 12, because that's how much you're going to pay per year for premiums, and then adding the out-of-pocket maximum. When you do the math, you can see here in this example that quote-unquote expensive platinum plan ends up being over $2,000 cheaper by the end of the year. Now, we do this example all over the country. It never comes out the same twice. Sometimes the platinum plan is the most expensive, but it is important for people to think and plan based on worst case scenario. The other piece about this is it shouldn't just be looking at what's going to cost the least at the end of the year, because there are some other considerations. For example, with the deductibles. So even if that bronze plan ended up being cheaper by the end of the year, it has a $6,000 deductible, which means you have to write a $6,000 check before that policy even starts picking up 60% of your healthcare. As compared with the platinum plan, it has a $0 deductible. So yes, you're paying more monthly, but now that additional cost is being spread out each month versus having to come up with a big chunk of money. Of course, you also want to make sure that whatever plan you pick covers your providers and hospitals and labs, and covers any prescription drugs that you're taking. Now, we are in a situation now, thanks to the Affordable Care Act, where we have the ability to review our options every single year. So people call all the time and they say, you know, I'm now on this drug and my plan doesn't cover it and I'm paying these huge amounts out of pocket. Well, my answer is, can we find you a plan for the year coming that does cover it? So we can't do anything about it right now, potentially, but moving forward, perhaps we can find a better plan. And this is also where I strongly suggest that people talk with their providers, not just about what they're taking right now or what their needs are right now, but to see if their providers can, you know, sort of see into the future a bit and anticipate if there's anything that you need to be taking for the year coming as well, so that you can make sure those drugs or labs or whatnot are also included in the plan. Now, I mentioned that we get a chance every single year to enroll, but when we get that chance, it's going to depend on what type of policy we have. So Medicaid applications are accepted year-round. As soon as somebody becomes eligible, they can apply. The marketplace does have an annual enrollment period. So for 2021 plans, that enrollment period's coming up, and it will be November 1st to December 15th in most states. Now, I say that because some states run their own marketplaces, California, for example, and many of the states that run their own marketplaces have longer open enrollment periods. So if you want to know what's going on in your state, you can go to our chart of state laws, and we have all of that information listed, and I've given you the link here. Medicare also has an annual open enrollment, so that's from October 15th to December 7th every single year. And this is the opportunity for you to either drive back and forth between those two lanes. So if you're in an Advantage plan and you'd rather be in Original Medicare, you can do that now. Or it's the opportunity to change your Part D plans. And this is particularly important because I got lots of questions about specific drugs not being covered by the Part D that they happen to be on. Well, now's the opportunity to make that change if that's appropriate for you. Now, marketplace plans and Medicare plans are calendar year plans, which means even if you pick a plan the first day of open enrollment, they don't start until January 1st. So important to make sure you plan and keep coverage through that time period. Now, employer plans also have an annual enrollment period. Most of them are also typically in the fall to line up with a calendar year start, but not always. So if you have an employer plan, really important to check your employer. And then if you experience a qualifying event mid-year, like losing your job or moving to a new state, that actually triggers a special enrollment period where you can go and buy a new policy in the marketplace outside of open enrollment. Now, unfortunately, even if you pick the best health insurance policy that's available to you, chances are you're going to get some sort of claim denial at some point in this experience that you're dealing with. So what do you do when the insurance company says no? I strongly encourage people to avail themselves of the appeals process. So there are generally two types of appeals. Internal appeals are when you go back to the insurance company and you essentially say, please reconsider. External appeals are when you go to an independent entity. Typically it's run through the state health insurance agency, but it's a little different in each state. And this independent entity looks at all the facts and then makes a decision as to whether or not the insurance company should have paid. Now, we know that somewhere between 40 and 60% of all appeals are decided in favor of the patient. So conservatively, we're talking about 50% of the time when the insurance company says, no, we're not covering it, they're getting it wrong. We also know that of the millions of claims that get denied, less than 0.5% get appealed. So when you think about the fact that 50% of the time the insurance company is getting it wrong, and less than 0.5% of the time people are appealing, that's a huge place where we're seeing people run into financial problems. So the answer to a lot of your questions that I got ahead of time are going to be, you need to appeal the decision. But you do have to ask your healthcare team for help, because most of the time the decision is going to hinge on whether or not a particular service or drug or treatment plan is medically necessary. That's the legal standard. And for you to be able to prove that medical necessity, you're often going to need some supporting evidence from your healthcare team. So really important to engage them in this process. Medicare also has an appeals process. It's slightly different depending on which lane you're driving in, but I've given you some information about where to go for more details. And then finally, and I know I'm almost up for time, but I did just want to quickly talk about what's going on in this country and what could potentially be happening. There is currently a case pending in front of the Supreme Court called California v. Texas, challenging the constitutionality of the Affordable Care Act. Now, the thing about the Affordable Care Act is it is not a perfect law by any means, but it did some pretty groundbreaking things for people with pre-existing conditions, including making sure that insurance companies couldn't deny you or charge you more for an insurance policy just because you have a pre-existing condition. So that case is currently pending. Of course, I'm sure you know, Justice Ruth Bader Ginsburg passed away last week. So there is an open seat on the court. And so it really sort of throws things into a little bit of limbo. But there's been some poor, inaccurate reporting in the news, and I just wanted to clear up what was going on. There's 5 possible scenarios. And different scenarios will obviously lead to different outcomes. But this is an opportunity. If you want to learn more, we have some blogs about this at triagecancer.org. But I will just say that this is absolutely an opportunity for advocacy. A lot of the questions that you also sent in, there are no good answers, because either Centers for Medicaid and Medicare Services hasn't decided to cover a particular treatment. There's a big issue with the cost of drugs in Part D plans. And all of those results, or the way to solve that problem rather, is through advocacy. And so I know you're such an engaged community that I think you could certainly make quite a bit of noise and have a huge impact. And Triage Cancer wants to be able to support you in whatever way we can. But please also know that there are lots of other factors associated with the financial stress that can come from a serious medical diagnosis, and we do have resources to help you. And if you are stressing about how to choose your health insurance plan for the year coming, we do have a webinar coming up, and I invite you to join us, and all of the services that we provide are free. So I'll leave up my contact information. And Muriel, I'm not sure if I'm taking questions now or at the end.
Thank you so much, Monica. I do have some questions for you. If you have to run, we'll let you answer them now, but otherwise it would be great if we could move on.
I'll hang out as long as I can.
Okay, great. If we hear babies crying or whatever, we'll know, okay?
Thank you.
Okay. And now, oh, by the way, the big takeaway I took from your presentation, Monica, is appeal, appeal, appeal. And that, I think, is the takeaway for everyone. What do you think?
I had already muted. Sorry. Absolutely. 100%. It can't, my philosophy is it doesn't hurt to try.
There you go. Okay, thanks so much. And be sure and check out the Triage Cancer site, folks. It's so great. We hear wonderful things about it.